Okay, thank you everybody for joining us. This is our shoulder events meeting tonight, and we've got Helen Mullet and Dave O'Brien both speaking, and we have Helen with us now, and we've no video, but we're able to see his presentation and listen to him. So without further ado, Mr. Mullet was appointed as consultant orthopedic surgeon and shoulder specialist in 2005. He's an honorary senior lecturer at the Royal College of Surgeons, and he runs a shoulder clinic in the National Orthopedic Hospital and practices in Santry Sports Clinic. He specialises in all types of shoulder surgery, including arthroscopic reconstructive surgery, and has particular interest in management of shoulder instability and rotator cuff injuries. Helen routinely treats professional athletes. He's active in research and optimising return to play, and he lectures nationally and internationally. He's going to talk to us now about management of shoulder instability. Helen, thank you very much for joining us. I'll hand over to you now.
Thanks very much, Pat, and thanks for the very kind invitation and for your introduction. I'm sorry, just with the technical glitch, you won't be able to see me, which is probably no bad thing. So I'm going to talk a little bit about management of the collision athlete and where we're at in 2024. So one of the issues with the collision athlete is the high rate of dislocation. So in the standard population, you can expect 23 out of 100,000 people per year to dislocate their shoulder. This is 98 in the young males. And if you look at the collision athletes, their rate of dislocation is 100 times greater than the general population. And in fact, if you look at the recreational rugby players, it's even higher than that. And this, apart from ACL, this is the injury that's going to take the player out of their game for the longest length of time. And the reason why these injuries are increasing in severity is, well, the obvious thing is the increasing player size in all codes, Gaelic football, hurling, rugby, training leading to greater muscle mass, greater endurance, increasing speed of the game, and increased professionalism, both in GAA and obviously in professional games such as rugby. In rugby, there's changes in the tackling technique have led to increased severity of shoulder injuries. The ball is in play for a longer period, and the upper body is involved in the tackle rather than the more traditional tackling around the ankles. They're also at the higher level of the game, there's a return to play pressures, particularly with increased number of games. And the player factors we come across are if they've had a previous injury, either to that joint or to other joints, and patients who have hyperlaxity or increased risk of having shoulder instability. There can be issues with altered proprioception, particularly after injury and surgery, fatigue, and the timing. And we did a study looking at the timing, and certainly in the last quarter of the game, you were most likely to be sustain a shoulder dislocation. So for these collision athletes, we tend to see high energy injuries. We see a lot of bone lesions, either on the humeral head, as in the upper image here, or in fact on the glenoid. You can see where the arrows are. This is a big bony Bankart. And this is what we see if we do a scope arthroscopy. We see a lot of osteochondral damage, so a lot of damage to the labrum, but also osteochondral lesions due to the violence of these injuries. And so if you're playing high-level Gaelic football or rugby, you have approximately a 1 in 8 chance of dislocating your shoulder over a 5-year period. So when the young player comes in with his parents and they you know, if you're doing an arthroscopic stabilization, say, will this be normal? Will his shoulder not dislocate? Say, well, if we bring his shoulder back to normal, the chance of him dislocating it is about 1 in 8, probably about 15% is normal. So for a collision athlete, they need a shoulder that's in fact more stable than a normal shoulder. And particularly the sports we play, you know, Gaelic football, hurling, rugby, the range of motion is not as important as the robustness of the reconstruction. And, you know, the patients are much place much greater value on a stable shoulder than other issues such as cosmesis for arthroscopic stabilization. So when we look at our surgical menu in terms of the soft tissue reconstructions, we can look at an arthroscopic labral repair. This can also be done in an open fashion. We sometimes have to repair the capsula, Hegel repair, and increasingly where there's a big Hill-Sachs lesion, we also anchor the soft tissue into the Hill-Sachs. This is called a remplissage. On the bone end of it, the most common type of procedure we do is a latch-shaped procedure using 2 screws. It can be done using 1 screw, which is called a Bristow. And we mainly reserved for the revision setting, we can use an iliac crest graft, which obviously has donor site morbidity, but may be essential if they have a very small coracoid, or if in the case of a revision setting. So when we're deciding what procedure to do, we look at the patient, we look at their age, their sport, what position they're playing, and their aspirations. So, you know, are they going to be playing their sport long term, or perhaps they're in 6th year in school and they're going to give up rugby, or they're going to change code and go to a sport that's less likely to cause injury. And then we evaluate them in terms of their clinical examination, and then look at glenoid bone stock, humeral bone stock, and the soft tissue condition, and then come up with a plan as to what is the most appropriate reconstruction for the player. And as we go from the less invasive arthroscopic labral repair to open Bankart repair and Lajet procedure, we have increasing stability. So in the arthroscopic labral repair, this involves introducing a camera into the back of the shoulder, and then through small tubes or cannulas, we prepare the glenoid and then place anchors and then reattach the labrum. So we're basically restoring to the anatomy to its pre-injury state. So the candidates for arthroscopic stabilization generally are patients who do not have significant bone damage. I often do it in patients who have an acute single dislocation. I also do it if they have both an anterior and a posterior labral tear, because the posterior labral lesion is much easier to address surgically through an arthroscopic technique. So if they have anterior and posterior, generally do it arthroscopically. So if we then look at the results, of arthroscopic stabilization in anterior shoulder instability, so in this paper, the rate of recurrent instability in the collision athletes was 29%. And this is another paper which is often quoted in the literature, is from Burkett and De Beer, and they looked at arthroscopic stabilization, and in those who had bone loss, particularly on the glenoid, if they had glenoid bone loss over 25%, which nowadays people would go straight to a Lajet on, but in this era of evolving era of arthroscopic techniques, they were performing an arthroscopic technique. In the collision athletes, their recurrence rate was 89% of those with significant bone loss. And Jaap Willems from Amsterdam, they would have been treating probably a less vulnerable group of patients in terms of recurrent instability, because they weren't treating too many GAA or rugby players in the Netherlands. But when they looked at the long-term outcome, approximately a third of those they treated with an arthroscopic stabilization had redislocated 8 to 10 years. And the problem with the arthroscopic stabilization, one is that a normal shoulder is not strong enough for a lot of collision athletes, but also it's difficult to address other issues such as bone loss or capsular laxity. And that what we see in the arthroscopic technique is they may do well for a number of years, but then have a late failure. And this paper by Pascal Boileau, where is the instability severity index score. So you look at their age, whether they're less than or greater than 20, what kind of sport they participate, whether it's contact or non-contact, whether they've bone damage on their X-ray, and you rate it out of 10, and this is meant to predict failure of arthroscopic stabilization. Well, if we look at this in our young contact players, 90% of them will be deemed unsuitable for an arthroscopic stabilization. And when we looked at the risk factors for arthroscopic stabilization in our series, it was less than 20, glenoid bone loss, humeral bone loss, hyperlaxity, number of dislocations, and those that had a greater number of anchors had less likely that they would fail. So when we look at the increasing stability with open procedures, particularly the lateral procedure, so lateral procedure is ideal, particularly if they have glenoid bone loss or glenoid erosion. It has a very low recurrence rate, and it's technically relatively straightforward. So the idea of the lateral, for those that aren't familiar with it, we would call it triple block effect. The first block is the coracoid, which we've osteotomized and then transferred to the front of the shoulder. That's probably the most dominant feature of the surgery, is the effect of the bone. The second effect is the sling effect, because we pass the conjoint tendon through the subscapularis, and that has a very powerful effect, particularly in abduction, external rotation. So just the position that your arm is in when you're tackling. So it really is very good for reducing apprehension in that position. And then the third effect is the capsule repair, which is probably the least important of the three effects. So the patients, the collision athletes that I generally go straight to Latarjet would be those with glenoid bone loss, humeral bone loss, if they've had previous failed soft tissue procedures. You know, in the collision athletes, if they've had more than one dislocation, if they're hyperlax, and often it's a kind of a relative indication, but if I've done a successful Latarjet on one side and they're coming for surgery on the other side, or in fact, if one of their relatives, if the brothers had a Latarjet, I might just go straight to a Latarjet rather than arthroscopic if they had a good experience of that. And if we look at this paper looking at Latarjet versus Bankart, we can see in all these domains, looking at return to running, training, competition, and recurrence rate are all better with the Latarjet technique. And we looked at a series of my patients who were all young athletes, so they were all around the 19-year mark, and they were all playing contact sports, and a lot of them playing at a competitive level. And we looked at the return to play was almost 90%, and the redislocation rate was 4.8%. So 4 to 4.8% in this group is a very acceptable figure. This was an interesting paper by Pascal Boileau. So they looked at the long-term follow-up of the arthroscopic Bankart versus Latarjet. And if you look at the Bankart, they do well initially, but if you follow them out to 5-6 years, the failure rate is coming up to 25% versus the Latarjet. If the Latarjet is doing well, it's kind of flat lines in that it's going to continue to do well. Finally, I'm just going to a few thoughts on the first-time dislocation patients, which often there's a kind of a clinical conundrum as to what to do with them. Again, they kind of fall into the whether we're going to definitely do surgery, whether we're definitely going to go conservative, or the more difficult group are really those where it's up for discussion really as to whether we're going to operate them, and that might be down to their age, their sport, where they are in their season, where they are in their career, and other kind of social factors, you know, school, college exams. So these can all be factors. And then when you're dealing with the higher level player, you know, you have team influences, you have manager, physio, you have all these other stakeholders. You know, particularly if you're dealing with the higher level rugby player, they may be contracted centrally, and then they may have be under duress to play for one team versus the other, and all of that comes into the mix. So for me, the definite indications for the first time dislocation is obviously if it's irreducible. If you can't reduce it by a closed means, and you're going to have to open it to reduce it, then I would fix it at the same time. This is unusual. If they've persistent instability, I mean by this that if they're reduced in the emergent department and then immediately pops out again, that's a sign that they have a significant instability. Usually repair them. In the older, generally over 40, if they have a rotator cuff repair requiring repair, I would also repair the labrum if necessary if they've associated fracture. And generally, the high-level collision athletes, generally we stabilize them first time. So these are the kind of issues you see if they've got a significant bone damage or associated rotator cuff, or in the bottom in X-ray, you see they have an avulsed greater tuberosity and associated with a first-time dislocation. So we're going to fix that. So I was involved in an international consensus group where we looked at the factors in terms of first-time dislocation. And for those relative indications for non-operative treatment, so if they have a low risk of recurrence, if they don't play any collision sports, or if they're older, if they want to avoid surgery, if they have low functional demand, if they have no significant glenoid bone loss, and those greater than 30 or less than 14 have a lower chance of redislocation, and also those in season if it allowed them to get through the season. So we also look at the, the reduction history. If they dislocated their shoulder, was it difficult to reduce? Did they have to have multiple attempts in the emergency department? That often can be a sign that they have a significant Hill-Sachs lesion. Also, if they have a history with the other side, if they've dislocated the other side and needed surgery, I will often go straight to surgery on the new side, if you like. On their examination, if they have I won't dwell too long on the examination because I know that David O'Brien is going to talk to that, but if they have mid-range instability, and then on their radiology, whether they have a significant bone lesion, either that being a bony Bankart or a Hill-Sachs lesion. And then often what is very important is the player factors, their sport and position. For example, if they're playing in a less vulnerable position, for example, a scrum half in rugby versus a fullback or a back row forward, the level that they're playing at the time of season, there may be an influence on impending fixtures. So that if they're a very important person and they're in the team and there's an All-Ireland final in 6 weeks, you might try and get them through that, and also where they are in their career. So in terms of the examination, and Dave is going to speak to that, so I'll just move on. And so the evidence in 2024, so we know that there's an unacceptable high risk of recurrence in the young athletic population, and we know that surgical intervention can reduce that recurrence rate. And also there's an improvement in quality of life conferred by surgery. So this long-term follow-up by Hovelius, a 25-year follow-up, they showed a recurrent dislocation rate of 72% in those aged between 12 and 22. So an unacceptably high rate of recurrence. In this study where they randomized patients, 88 patients, so they either did an arthroscopic stabilization or they just did an arthroscopic washout, the recurrent rate in the arthroscopic washout was 47% versus 12%. And we did a systematic review and meta-analysis. We looked at all prospective clinical studies comparing arthroscopic Bankart repair and conservative management. They were all peer-reviewed English language full text available studies. So in this group, you can see these studies, some very well-known studies, such as the Kirkley study, Dickens studies, Arciera's study. So these are all prospective randomized trials between non-operative and arthroscopic Bankart. So we had 270 in the non-op group and 299 in the arthroscopic Bankart group. They had similar demographics in terms of, as you'd expect, largely male and young age group, with an average follow-up of 66 months. And if we look at the outcome, then the recurrent instability in the arthroscopic stabilization group was 9.7%, very acceptable. In the non-op group, it was 7 times higher at 67.4%. And of the group that were treated non-operatively, 46.7% then subsequently went on to have surgery. There wasn't a huge difference in the initial return to play. Finally, then looking at what about the issue of recurrent instability causing significant and progressive soft tissue and bony damage. So if we look at the ALPSA lesion, which is where the labrum is avulsed and heals medially, this was greater in recurrent cases. There was also more injuries to the glenohumeral joint capsule. There was more cartilage injuries with progressive number of events. And the Hill-Sachs lesion, again, very significant factor in recurrence rate following surgery. So the Hill-Sachs lesion became larger, deeper, and wider, and more likely to need an open procedure with progressive events. And also, most importantly, you get with more dislocations, you get more glenoid bone loss, and you're probably looking more likely at a bony reconstruction. So we did a study where we looked at either MRI arthrogram or blood MRI, i.e. MRI scan done shortly after the instability event. And we looked at a total of 871 patients. They were 200 primary, i.e. first-time dislocators, 571 recurrent, i.e. they'd had more than one dislocation, and 100 who were revision procedures, i.e. they'd had previous surgery, and we looked at their MRIs and MRI arthrograms, and we noticed that the difference between those with primary instability versus recurrent, the rate of glenoid bone loss was 26.5% in the primary and rose to 56% in failed stabilizations, 43.4% if they'd had more than one dislocation. So I think we've kind of established that you get more damage with repeated dislocations. The other issue is that if you repair them early, I think like the ACLs, you have a excellent healing environment, and you know you're much more likely for the tissue to heal. So thank you. I'm not sure where we are in terms of questions, whether we take them at the end. This is my website. There's some number of little videos on the website that might be helpful.
There's one question here just came through before we move on. We normally ask questions, just do discussion at the end, but is there any evidence on the difference in return to play duration? For example, rate of recurrence after a 6, 9, 12, or 18-month return to play? Have any opinion on the importance of rehab duration before return to play?
Yeah, that's a very interesting question, and my colleague Adele Fanning in Santry has done a lot of work on return to play and looked at isokinetic testing and various biomechanical testing. Yeah, I think they're probably, you know, if the patient hasn't rehabbed adequately, then their rate of recurrent injury is higher, and that's something we're looking at. We have data from their up to 2 years, but we'll be looking at their scores in terms of, I suppose, looking at assessing their rehabilitation and comparing that to recurrent instability. But it's a good question, and I guess it's a work in progress.
Thank you. And I'll just ask a question. I mean, I remember there was a lot of talk over the position of immobilization of the shoulder following relocation of a primary dislocation. And so, I mean, what's the sort of current view on what's the best position to actually immobilize the shoulder to minimize a further relocate or dislocation, and for how long will you immobilize after that first dislocation? And for example, somebody even who's not involved in regular collision sports, a first-time dislocator.
Yeah, I mean, that's also an interesting question. I mean, the literature that kind of led to a vogue for mobilizing in external rotation was Japanese, a very good surgeon, Itoi, and they did a study where they immobilized patients in external rotation, and they did an MRI scan in external rotation and showed that you reduced the Bankart lesion in external rotation. So they had their patients immobilized in external rotation, like quite an extreme external rotation, which, you know, would be difficult, for example, getting through a door. They were so externally rotated, and they showed a significant reduction in recurrent instability. Now, I suppose there were two factors there. One, their sports are generally non-contact, and two, the Japanese patients were very compliant. They wore their brace religiously. So, and no other group has been able to reproduce that. So I don't, there's nothing at the moment to support anything other than a simple sling. And for the first time dislocators, young dislocators, I may keep them in sling for 2 or 3 weeks. If they've recurrent instability, I don't put them in a sling at all. So it doesn't make any difference.
Okay, thanks, Hannon. We're going to thank Hannon for his presentation. I hope if you are able to hold on to us, hold on.
Sure. Yeah.
And I'm going to bring in Dave O'Brien now. So, Dave, I hope you're there.
I am indeed. Hopefully, you can hear me.
You can hear loud and clear. Dave's a consultant orthopedic surgeon, a shoulder specialist, and an assistant professor, and adjunct clinical lecturer to the UCD School of Medicine. Internationally, he completed his fellowship training in all aspects of elective and traumatic shoulder and elbow surgery at Sydney Shoulder Research Institute, and then furthered his a fellowship training in sports surgery and uplimb surgery in Tampa, in Florida, in the US. He currently works in University Hospital Waterford and practices in UPMC, Whitfield Clinic mainly, and I still believe he's doing clinics up in Odd Even as well. So, Dave, you're very welcome, and I'll hand over to you if you want to share your screen. Great to hear what you have to say on examination.
Seeing as I don't have slides, at least you can put a face to the voice. So I could quit Teams and come back in, but there's not a huge amount on the slides in terms of imagery. But the first thing with any of these, when a patient comes into you, you're going to start with going through your history. What was the episode? What was the event? And there are often very clear cases where the patient has definitely dislocated. The easiest ones for us are when there's an X-ray of it out of joint and then back in. Often there'll be a clear history of a definite dislocation with deformity that was reduced pitch side, and those ones are quite easy. But sometimes there can be a little bit more subtle presentation, a feeling of something giving, a feeling of it coming out of joint and back in again, but without it having rested out. So these subluxation like episodes, and that can relate to a dislocation. It can relate to a labral tear. It can relate to superior labral tearing, or even in the slightly older population, biceps subluxation from the groove. So you want to start with your history and go through what happened. What was the mechanism? Was there the contact or collision? And the research work that we did with Hannon and it was David Montgomery, Connor Montgomery, who published the paper following on from the dislocation types in rugby and the different mechanisms, and adding our own classification to that as well. But whether you land on your elbow, whether you land on your shoulder, do you land with your arm outstretched in a try-scoring position? So are you in the cleaning out position, the kind of poach position? And those different mechanisms will give you a good idea of what kind of trauma the patient has suffered and what the likely direction of dislocation is. You also want to know, did this occur is it a very high energy injury? Could it be a posterior dislocation? And that can happen in the contact athletes. The other ones who would have that are people who might have a seizure, which is obviously unlikely or uncommon in the athletic population, but can occur. Or if there's a major trauma, as opposed to the typical contact sports that we talk about, you may have an athlete who's on motocross or something like that, and the high energy trauma can result in different mechanisms and patterns of injury. As Hannon's slides there alluded to, the number of episodes is key, and there's a lot of debate over the first time dislocator, and I think that was very well sort of elucidated in Hannon's slides as to which patients are definitely demonstrate some simple basic instability examination on him. So we'll start going through with the athlete. You go through I go through a neck examination and then a cuff exam. The neck exam is fairly rudimentary. So if you turn your head from side to side like that, you want to make sure they have a full range of motion and it's not precipitating pain. Head up and head down like that, and then over side to side like that. So moving on quickly from that, ensuring that you've already said there isn't an obvious neurologic deficit. You can check for sensation. So bring your hands up like that. Is the feeling the same in both sides? And working your way up the arm, checking the dermatomes, making sure it's the same. And then do a very brief peripheral neurologic examination. Keep your fingers spread wide apart. Don't let me squeeze them together. Make 2 circles like that. So we're making OK signs, and make sure I can't break the circle there. Keep the wrists cocked up. Keep them up like that. Don't let me push them forward. We'll turn the hands face up like that. So checking biceps, turn the hands face down, push down really hard, checking triceps like that as well. When I'm doing the biceps and triceps, for neurologic examination, I'll also check the biceps by getting them, when they're in this position, to keep the hands face up. Don't let me turn them over. Good. And if there's any biceps related pain or issues, that'll show up at that stage. And then, because we're in this position, go through a simple cuff examination. So first of all, check range of motion, twist the arms out like that and bring them back straight. Hold them straight, don't let me push them together. So checking posterior cuff. Put the hands on the tummy, bring the elbows forwards in front of you. Don't let me push backwards. And this is checking subscapularis at the front. All this in clinic takes only a few seconds to do. Bring the arms up, hold them there in that position, supraspinatus, and then turn the arms over towards ground, infraspinatus, and then turning towards the camera there. Bring the arm up like this. Hold the arm there, don't let me push it downwards. This is separate posterior cuff for the teres. So we had infraspinatus down here in position 1 and teres up here in position 2. You can also check range of motion with internal rotation and check their comfort in that position, as well as full range of motion with full elevation, and put the hands up like that for me. And make sure they're comfortable putting the hands up and behind the head like that. Then I'll bring the patient over and lie them down to check the instability features. So if you lie down there for me towards the edge of the bed. Generally the mainstay, come over towards the edge there for me. See, hopefully we're visible on screen. I'll try not to get myself in the way. We're going to first of all check to see what the external abduction external rotation that they can tolerate is. And he's got normal abduction external rotation there. So obviously in very unstable patients, you may start to rotate, and a patient with significant bone deficit, for example, is unlikely to allow you even get this far. If they're a bit uncomfortable as you get around there, you can check for instability by putting posterior pressure on the humerus and then repeating the process. Normally that will make the unstable patient much more comfortable and you can restore external rotation. This is for the anterior instability patient. After we've done that, when you've got the pressure on, if you then take your hand away, you'll see a reaction, and that will give you an indication. That's the relocation, or sorry, the as we do that, you'll see as you take your hand off, the shoulder will be able to sublux forward again, and they'll become apprehensive again. Stand up there for me again. One thing I didn't say as I was going through there is I was focusing on more on anterior instability, but as we look for posterior instability, we can do our modified O'Brien's test. I'll tilt the camera up a little bit there. So modified O'Brien's test is like the supraspinatus testing with the arms in the plane of the scapula, but this time we bring it across the front. And this is a test that Steve O'Brien described as part of the 3-pack for testing biceps, but we turn the thumb towards the ground. And now if we apply pressure from above in a patient with posterior instability, there will be pain, discomfort, or inability to resist there with discomfort at the back of the shoulder, as opposed to with the biceps where to be towards the front. So with that in mind, going back to the posterior instability, if we lie down again, there are various versions of a posterior load and shift, or looking for Kim lesions or posterior labral lesions, but essentially the posterior load and shift, and I'm standing slightly out of the normal position to do it, but you can put posterior pressure on the shoulder, and in this position you're in the line of the glenoid, so it's, I'm not sure if you can see there, but as opposed to being straight vertically, I have his arm across the chest and pushing downwards, And as we're pushing downwards like this, we're translating the humeral head posteriorly, and then we can bring that out to the side. And much like you would experience in your pivot shift assessment in the ACL, in this case, the ball is subluxed, much like you'd sublux the lateral compartment in your pivot shift for an ACL. And as you bring the arm down, it'll pop back into place in somebody who's true posterior instability, unless their musculature is inhibiting you and preventing you from doing it. But even if the musculature will stop you doing it, you can put posterior pressure and flex and extend the elbow like the shoulder like that, working your way around, and that'll give you an indication of posterior. That'll give you an indication of posterior pain, and posterior pain on loaded shift will be more suggestive of a posterior instability. The posterior instability can be a lot harder to pick up because the history is often a lot less clear. It's often more in relation to recurrent, less traumatic episodes. It can be due to a single traumatic episode, but the presentation doesn't tend to be the typical instability presentation. It's more discomfort at the back of the shoulder, often with certain maneuvers, perhaps with going to the gym, certain bench pressing, or if they happen to be lifting free weights on an incline press. And that tends to cause more discomfort at the back. It's sort of typically described in the patient that the athletes where their hands are straight in front of them like that because of the inclination of the glenoid, which is not straight AP, it's inclined because of scapular protraction. And due to that anteversion of the native posture of the glenoid in relation to the coronal plane, to get that posterior load, unless you have a natively more retroverted glenoid than normal, to get that posterior load, you need a significant impact, but usually with your arms in close. That could be an impact with the ground, with your arm across your body. It typically is described in the sumo wrestlers and the American football linebackers because they have their hands up like that and they're putting pressure on in that mechanism there. So I suppose to summarize, first of all, when you have a patient who has a clear history, it makes things easier. But you still need to go through the examination in detail. When there's a little bit less certainty of the clinical presentation, going through the examination should help you in probably 99% of cases elucidate what you believe the issue to be. Whether that be anterior instability, posterior instability, combined anterior and posterior, sort of more 360-degree labral type tear, or a slap tear, and that modified O'Brien's test I demonstrated you is a good one for slap tear. The other component of the O'Brien's test is the so-called 3-pack, the throwing test. So resisted overarm throwing, where you get them to go through a throwing motion, then resist them, and then you feel the pain and you see the apprehension as soon as you try that. So they can give you a better indication of a superior labral tear. But the history, the examination can give you that in the vast majority of cases, and usually the scan is confirmatory after that. Occasionally it's not quite clear, so maybe 95% is clear, but the other 5% or so it's not quite clear, and that's where the MRI, the MRA can help. And in a very, very small number of patients, sometimes we reach a point where we would undergo a diagnostic scope to try and then determine the pathology within, and then depending on how likely one thing or another was, it may be a case of just a diagnostic scope, or it could be a case of diagnostic scope proceeding to either arthroscopic stabilization or Latarjet, depending on the findings. I think that pretty much covers there's obviously an enormous amount more that you can talk about with shoulder examination. I'm not sure if there's any questions there. Pat, have any questions come in, or?
Yeah, there's no questions going through the chat function yet, and so. Okay. But what we do is we'll move on to the research summary, and then we'll bring yourself and Hannah in for a discussion. We started about 10 minutes late. We're still about 10 minutes to go. So look, okay. Thanks. That was a great demonstration. Thank you for your patient, Michael. They did very well. And so okay, so I'm going to get Karen who's just going to do a 5-minute summary of the research paper that we sent out for those who are interested to read. It's a paper that's particularly important, I think, from the physiotherapy perspective. So we'll do a small summary, and then we'll just bring everybody back in for a quick discussion before we finish. Thanks again, guys. Okay, Karen, thank you.
All right, thanks a million. So I hope that you can see the screen there. So today's paper was an acute rehabilitation following traumatic anterior shoulder dislocation, pragmatic multicenter randomized control trial. This was published earlier in the year by Carney et al. The aim of the study was to compare the clinical effectiveness of 2 rehab interventions in adults with a first-time traumatic shoulder dislocation. It was a randomized control trial, as I said, that was conducted across 41 hospitals in the NHS in the UK. The exclusion criteria were neurovascular complications, bilateral dislocations at the time of injury, if they'd been randomly assigned previously in the study, if they were unable to adhere to the trial procedures, or if they were unable to attend physio within 6 weeks of their injury. So the groups were randomized on a 1-to-1 basis, and all participants were treated by clinicians who were blinded to the treatment allocation at their initial assessment, but however, it wasn't possible to blind clinicians or participants after that. So the interventions were either 1 session of advice, supporting materials, and the option to self-refer to physiotherapy, or the same advice, supporting materials, and an additional physiotherapy program. If you go back to their previous paper, which was published in 2021, that'll give you an idea of the management strategy. So there was 4 phases, from immobilization to range of movement, shoulder strengthening, and they did have a phase on return to sport, but there was no exercises specifically stated for that. The additional physiotherapy group then obviously would have had access to that, but they also had 30-minute physiotherapy examinations for up to 4 months from the date of randomization, where they would have had personalized teaching of the program and bespoke tailored treatment if necessary. The outcomes they looked at were the Oxford shoulder instability at 6 months, quick dash, the EQ patient report outcome, and complications. They did a priori power analysis before the study began, and it indicated that they needed about 478 participants to show a 4-point difference in the outcome measure and account for 20% loss to follow-up. And the analysis was an intention to treat based analysis. And they also looked at using multiple imputation for missing data. So as you can see from figure 1, they ended up with about 180 in the primary analysis group and 174 in the comparative group. The participant demographics, so they were typically non-sporting population with an average age of in or around 45 years and predominantly male. At 6 months, there was no difference, or any of the follow-up time points, but particularly 6 months, which is what they were looking at, there was no difference in the outcome scores between groups. There was no difference in any of their secondary outcomes, quick dash or the EQ 5D5L, and there was no difference in the incidence of complications, the most prominent of which was a torn rotator cuff.
you.